Thank you very much. The topic which have been allotted to me by the organizers is malignancy, erectile dysfunction, and PDE5 inhibitors. I am Dr. Suresh, working as a professor in psychiatry from NIMANS, Bangalore. So, actually, I would like to put a disclaimer telling that I have not seen much patients with malignancy with ED, but however, couple of patients who have been reported with malignancy and depression and other side effects with regard to medications who has been reported to NIMANS, I have seen them. But considering the topic allotted, I did my Scopus review, or what we call it as a selective review, and I'm presenting those. And when I did the literature search, the whole gamut can be divided into two parts. One is malignancy and erectile dysfunction, prevalence and causes. The next one is malignancy and use of PDE5 inhibitors. What are the indications and what are the effect on ED and cancer treatment? So malignancy and erectile dysfunction. The erectile dysfunction is very common as soon as the diagnosis is made. So it can be both directly and indirectly, the erectile dysfunction can occur. As soon as a person is diagnosed as cancer, invariably the grief starts, basically shock, denial, anger, depression. So because of those issues, the person may not be able to involve in sexual activity. So the diagnosis of cancer itself, or else the medication which have been given for the diagnosis or a procedure which has been done, chemotherapy, radiotherapy, and surgical procedures can also cause erectile dysfunction. So that is directly. Indirectly is depression because of the diagnosis or else side effects of various medication, and loss of hair, body image disturbances, anxiety, what will happen to my family members, fatigue, pain, psychosocial issues, I am unable to pay for the treatment or the treatment is very costly. So those kind of issues will start erectile dysfunction. The erectile dysfunction is not only in the acute phase of the diagnosis and the treatment, but invariably many of these illnesses which regard to cancer, the sustained erectile dysfunction occurs even after 6 months, 1 year, and also if the person is survived after the cancer treatment, invariably after the 2 years of follow-up, we find erectile dysfunction, and which is not been addressed in many of the situation. Invariably, the oncologist or various doctors who are treating the patients with malignancy or cancer, they don't address or they don't ask about erectile dysfunction or else any other sexual dysfunction. The doctors feel very uncomfortable in asking. At the same time, the cancer patients finds it very uncomfortable discussing about this issue because the doctor may dismiss, telling that you are survived, that is more than enough. That is the way it will be looked upon. So various other causes of ED in cancer patient is age of the patient. Invariably, the cancers are seen in the elderly population, and how much the elderly population, the age plays a role. And also before the cancer, what was the sexual performance? If he had a problem before the diagnosis of cancer, that continues. Comorbid conditions like diabetes, hypertension, neuropathy, trauma, and so forth also plays a role. And of course, psychosocial issues, metabolic causes, hormonal imbalance, and chronic medical condition. So these have been considered as a erectile dysfunction problems, especially in the elderly population. But however, recently we have seen many younger population are being diagnosed with cancer. So in those conditions, we need to address, because invariably, if you ask them whether the cancer, the survival rate is 2 years or 3 years, if they say, they would like to say, yes, if I am there for 1 year or 2 years, I would like to have a good quality of life. So in cancer, one of the yardstick which has been used is what is the sexual satisfaction or the quality of life after diagnosing cancer, treatment, and how the sexual satisfaction is there. So now let's look into the chemotherapy. I will not go into the each and every individual chemotherapy drugs, but I will be making a summary of the whole chemotherapy. Invariably, the various chemotherapy has been given to kill those cells which are actively dividing. So these drugs, what they cause is, they cause neurotoxicity and vascular toxicity that control erection. That invariably causes the erectile dysfunction. Invariably, there have been 2-year follow-up state. That means the patient has been diagnosed with cancer, chemotherapy has been given. After 2 years, he has survived. They found 40 to 60% of the patient who has undergone just a chemotherapy had erectile dysfunction. That means it's a huge number we are talking about. So invariably, chemotherapy has effect. Now moving to radiotherapy. Again, the prevalence has been seen, what kind of radiotherapy you are giving. Is it a complete irradiation or a brachytherapy? So prevalence is again depending upon where the exposure is there, 10 to 60%, and it is dose dependent. If the exposure is more than 50 gyri, then invariably the erectile dysfunction will be seen. Again, the radiation induced vascular or neural damage is the main cause, and invariably over a period of 2 years, the slow recovery occurs. So this is where the radiation therapy, how it occurs. Basically, neuronal damage, vascular damage, and muscular damage, and various pathways have been given. And there are recent literature which talks about using PDE5. How it can be done will be discussed shortly. And radiation therapy basically decreases CGMP, which has been already discussed. But however, where the PDE5 occurs, and brachytherapy is the only way we can decrease the neuronal damage and vascular damage. So invariably, we have to ask for those kind of brachytherapy to decrease the sexual dysfunction. Surgery. Again, what type of surgery? Where the surgery is done? Radical dissection is done. If you are going to cut the nerves, invariably it will be permanent damage. Invariably, the person may not have any erectile erection because whatever medicine we can give. So this will be another biggest headache. At the same time, vascular damage because of surgery. So post-surgery, how the person, the before surgery and post surgery, what is the sexual functioning needs to be discussed. And if it is a young patient, we have to ask what is his expectation, whether the surgery with cancer and at the same time survival, whether the survival without sexual function, will he be happy, and how we can conserve the sexual activity should be the goal of discussion, especially in young patients. So these are the various ways, the various treatment are there, various cancers are there, how the physical effect is there, and post-treatment adverse effect like loss of libido, arousal, dysfunction. So various things are there which has been clearly been discussed in various articles. I would like you to go through this American Society of Clinical Oncology, one of the important publication which is available. That is freely, we can go through this. Moving to the treatment option for ED in cancer patients. Invariably, if the patient is going through chemotherapy, choose the short acting. The best would be sildenafil citrate. Start with 25 and move to 50 mg, and rest if depending upon the performance and also the how the is be able to do. And invariably, the long acting should be avoided as much as possible when the patient is on chemotherapy, so that the drug interaction do not occur. Of course, the other drugs also can be tried. So this is the mechanism of action already has been discussed. I'll not go into this. Now, one of the important discussion which has been recently come in past 5 to 6 years is penile rehabilitation after the cancer treatment. So we are talking about erectile dysfunction. Penile rehabilitation is a place where when a patient has gone through chemotherapy, radiotherapy, and surgery, various neuronal loss will have occurred, vasculature have been destroyed. In such a scenario, how we can do penile rehabilitation? So the penile rehabilitation should be started as soon as the treatment of cancer is initiated. We should not wait. The person has been moved off, the treatment has been done, and then you start doing it, it will be too late. So we have to start at the earliest. So the assessment has to be started with urologist and psychiatrist together along with the oncology team. And invariably, if the surgery is surgical oncology is involved, we need to discuss about nerve sparing surgery, especially if they are doing in the pelvic area. So because that is the area where if you cut the nerves, invariably we will not be able to give any kind of erection. It has to be the PDE5 will not be able to useful. So invariably, one of the study which has been recently brought in is to start prophylactic PDE5 2 weeks prior to the start of treatment and 2 weeks after the completion of treatment, either full dose or small dose. They say that they have been found these using phosphodiesterase inhibitor has been found to be very helpful in cancer. But however, there are some studies they say yes, it's there does wonder, but another study says that it's not useful. But however, we need to consider this and we need to have a long-term prospective studies. And also, the sexual rehabilitation lasts for 2 years after active intervention is over. So how does this PDE5 works? Invariably, the studies have clearly said that by giving before the cancer treatment and continuing during the therapy and after the stopping the therapy, that basically chemotherapy or radiotherapy, if you continue this, you can decrease the ischemia, reperfusion, and denervation can be decreased. By that, not only that, the cancer outcome also improves. That's what the studies have been said. And these are the various treatment options, especially when the patient with cancer. Moving to the last part of my presentation, that is malignancy and PDE5, which I discussed now. Phosphodiesterase F enzyme is overexpression is seen in various malignancies, even in glioblastoma multiforme, that is especially the brain tumor. So in these, if you give PDE5, there is increased permeability of the tumor, enhanced chemotherapeutic effect of the drug. So this is an early part of the studies which have been found, and it also says that PDE5 has been found to be very useful in suppressing tumor cell growth, invasion, that is basically metastasis can be decreased, and it increases the apoptosis, that means immunity increases, and the tumor microenvironment immune suppression works beautifully. That's what has been the recent study which has been moving up. So the various tumors which have been found to be very useful in PDE5 is melanoma, glioblastoma multiforme, which I presented, lung cancers, prostate, breast, and colorectal. So these illnesses, PDE5 has been used as an open label trial, and it has been found to be very helpful. But however, some studies are negative in nature. That means it doesn't cause harm, but invariably it has shown as a negative studies. So these are the I will not go into this. The last part of this is how the PDE5 has been found to be very useful, and this is the International Journal of Molecular Sciences recently has been published. In that, they clearly say that by providing PDE5 inhibitors, it decreases the proliferation of the cell, decreases angiogenesis. If the angiogenesis is decreased, the tumor dies because there is no blood supply. Any tumor requires blood supply. Apoptosis, that means the cell will be killed. The cell goes into death, and chemosensitivity increases. These are the four important mechanisms PDE5 has been found to be very helpful, especially in cancer, by using this. To conclude, my dear friends, especially in malignancy, penile rehabilitation should be started at the earliest, especially in young patient. Of course, even in the elderly patient who says that the sexual functioning is very important, the quality of life, especially in cancer patient, matters most, and even the treatment. And also, the role of PDE5 appears to be promising at this point of time. Who knows if it works very well in next 5 years? In most of the patients who are on cancer therapy may have to be started PDE5. So this is where it stopped. Thank you very much for giving me the valuable time. Thank you very much to the organizers.